The first presenter will be Johann de Bono from the Royal Marsden, and Dr. de Bono is going to speak on new systemic therapies for prostate cancer.
Good afternoon. Thank you for your introduction, Bruce, and thank you for the invitation, Paddy, and the rest of the planning committee. It really is an amazing time in prostate cancer therapeutics. Unprecedented, I think, in the history of studying new agents in prostate cancer. The last 2 years have been truly remarkable. So my focus is going to be on systemic therapy for advanced prostate cancer, but part of my talk is going to focus also on our work on circulating tumor cells and their utility in this disease. So until 2010, only 2 systemic therapies had impacted survival in prostate cancer. Charles Huggins, a Canadian urologist working in Chicago in the 40s, showed that castration, i.e. deprivation of testicular androgens, actually had significant antitumor activity against advanced prostate cancer, and that became the standard of care until, I guess, 2004-2005, when the TAX 327 trial, fronted by and led by Ian Tannock and others, showed that docetaxel improved survival in this disease, advanced prostate cancer. For many decades, there was concern that this disease was chemotherapy refractory, and for many years we called this disease hormone refractory, and we called the combination of anti-androgens and castration therapy maximal androgen deprivation. I think I can incontrovertibly now say that this disease is not hormone refractory, that actually combined LHRH analog therapy and anti-androgens is not maximal androgen blockade. And I'm delighted to say now for our patients that we have multiple other new drugs that can really improve overall survival for this disease. So in the last 2 years, 4 new agents have shown a survival benefit for advanced prostate cancer patients. It is my conviction there's going to be actually several more coming down the pike in the next 2 to 3 to 5 years, with, for example, drugs like cabozantinib that's showing really impressive activity in this disease, and maybe PI3K/AKT inhibitors in combination with drugs like Abiraterone or maybe MDV-3100. What's clear, however, is that this disease truly remains hormone-driven in the castrate setting, probably, and with increasing evidence for this, that the cancer cells themselves are actually generating their own androgenic steroids. So Sipuleucel T, in a paper by Phil Kantoff and colleagues from the Dana-Farber Cancer Institute, has been shown in a randomized phase 3 trial in the pre-chemotherapy setting to improve survival, and that this is now, I guess, become standard of care in the pre-chemotherapy setting in the US. Although cost here is an issue, I guess we'll have to see about future trials of this agent in combination with other drugs that are coming along, perhaps like Abiraterone. The next agent that came along after Sipuleucel T was cabazitaxel. I was fortunate enough to work in San Antonio, Texas with Eric Rowinski, and Eric had a major interest in tubulin-binding drugs, and I was involved in the phase 1 trial of this drug, where we showed in that phase 1 trial anti-tumor activity in advanced prostate cancer, including activity in Taxotere or docetaxel refractory disease. That led me to propose initially a phase 2 trial, but then to run a randomized phase 3 trial of this agent in advanced prostate cancer. Abiraterone has also shown a significant survival benefit of almost 5 months in the final second analysis of the survival data against placebo. And finally, alpha-radin is a systemically delivered radionuclide. I will not comment much on that, but I'm very proud that my colleague at the Royal Marsden, Chris Parker, has led that phase 3 trial, which I hope will be presented in some weeks at ESMO in Stockholm. And these are the data in a bit more detail. I never dreamt really, when I started, I guess, treating prostate cancer patients, when I moved from Texas to the Marsden in 2003, we would actually have so many positive studies so quickly. And it's so exciting to see us have a major impact, not only on improving treatment, but actually improving our understanding of the biology of the disease, improving our ability to do biomarker studies in advanced prostate cancer patients, and now also developing surrogate markers, truly validated surrogate biomarkers of survival. And I'll come to that shortly when I mention circulating tumor cells. So what will the treatment paradigm be in 2011 and beyond that, when horizon scanning may be in 5 years' time? Well, I think where we are now, what we can genuinely recommend is that the standard of care remains LHRH analogs, probably as the first-line therapy, although some could argue that the anti-androgen bicalutamide could be used in the first-line setting, although I think that LHRH analogs must remain the preferred first treatment. On progression with advanced disease, one could add bicalutamide to an LHRH analog to try and reverse resistance, although usually the duration of disease or PSA control is short. At this juncture, one could add in Provenge to a patient progressing. In the UK, other therapy options in asymptomatic patients with a rising PSA, maybe low burden disease, would include low-dose steroids and diethylstilbestrol or DES. However, in a patient with perhaps rapidly progressing disease or symptoms or even higher burden disease, it would be entirely prudent to start docetaxel earlier rather than later, based on the TAX-327 data. Docetaxel does improve both survival and quality of life. Currently, we can only recommend abiraterone in the post-chemotherapy setting based on the 301 randomized phase 3 trial that I led with my co-PI, Professor Howard Cheer from Sloan Kettering. We await the results of the randomized phase 3 trial in the pre-chemotherapy setting, the 302 trial, which I hope will show a survival benefit in that space. However, crossover does become an issue because patients who got abiraterone in the pre-chemotherapy setting in this trial or placebo in that trial could now be crossed over to abiraterone post-chemo since this drug is available both in the US and Europe. This drug was approved by the EU fully this week. I think finally cabazitaxel is going to be increasingly used in these patients. I personally think cabazitaxel is better used earlier rather than later, but at present we can only use this. It's approved in the post-docetaxel setting, and my suspicion that it is going to be used probably in the post-abiraterone setting initially. Although sequencing trials are needed to try and elucidate the best way to give these agents, either sequentially or perhaps even in combination, for example, abiraterone and cabazitaxel. However, looking at the current randomized trials that are ongoing and other studies ongoing and horizon scanning, it is my suspicion that drugs like abiraterone will move into the earlier stage disease because we know, based on data from several groups, including, for example, Martin Gleep's group in Vancouver, that within weeks of castration, a cancer cell alters its transcriptional profile and is able to generate its own testosterone and androgenic steroids. So it is very likely that abiraterone is going to be used in earlier stage disease. And here in the UK, we have just amended our large randomized phase 3 trial called Stampede to include abiraterone in the first-line setting in patients with high risk or metastatic disease at diagnosis. Beyond that, I think Provenge may still play a role. After that, chemotherapy will be likely to be administered. It is possible that if the cabazitaxel versus docetaxel randomized phase 3 trial shows a superiority of docetaxel, which is my hypothesis, that cabazitaxel could replace docetaxel. And I'll show you in a few minutes that cabazitaxel is truly active in docetaxel refractory disease. I think that alpha-radin will continue to play a role, perhaps either as a single agent or maybe even in combination with abiraterone. Drugs like cabozantinib are showing significant promise. This is a c-MET and VEGFR inhibitor, and this is now in randomized trials, and it's our hope that this and other drugs will become a standard of care for this disease. Where do other bone-targeting drugs fit, like denosumab and bisphosphonates? In the absence of survival benefit, it is hard to make definitive recommendations, but these agents clearly improve the risk of skeletal-related events. I'm going to focus essentially on cabazitaxel and abiraterone, since these are the trials that I have led over the last 5 years. The cabazitaxel randomized phase 3 trial was called TROPIC. It was a randomized comparison of cabazitaxel, 25 milligrams per meter squared every 3 weeks with prednisone or prednisolone, up to a maximum of 10 courses against mitoxantrone in the TANAC regimen that was shown to improve quality of life but not survival. The stratification factors are outlined on the slide, and pre-medication was used on this trial to prevent the risk of anaphylactic reaction, which is very uncommon, and antiemetic prophylaxis was administered. This trial was probably one of the most, if not the most, statistically significant trial we had seen in advanced prostate cancer patients, with a 2.4 months improvement in median survival, both in the first and second line setting, with a hazard ratio of 0.7, as seen in this slide. The subgroup analysis confirmed that all patient subtypes benefited from cabazitaxel. This is now published in the Lancet paper in 2010. I should particularly point out that patients that had genuinely progressed, either during docetaxel treatment or within 3 months of stopping docetaxel, the patients that I would term docetaxel refractory disease, also had significant survival benefit from cabazitaxel. So in keeping with preclinical data, cabazitaxel has antitumor activity in docetaxel refractory disease. It is likely that the taxanes work in prostate cancer, at least in part through their effects on modulating interphase function of the androgen receptor. The androgen receptor remains a key driver of advanced prostate cancer. When I moved from Texas to London in 2004, one of the hypotheses that I put forth in one of my trials was that what was named hormone refractory prostate cancer was not truly hormone refractory, but remained frequently ligand-driven by ligand-activated androgen receptor. And we published a review in the British Journal of Urology outlining this hypothesis. Chemists at my institution a decade before had made a series of compounds based on the structure of pregnenolone, a precursor of testosterone and cortisol and estrogen. That was a potent and irreversible inhibitor of an enzyme called CYP17, which is upstream of aromatase, which is also known as CYP19. This compound was generated and designed by Mike Jarman, Jerry Potter, and Elaine Barry at the Institute of Cancer Research. Blockade of CYP17 results in a loss of synthesis of testosterone and estradiol, as well as a fall in androstenedione and DHEA. A concern had been propounded that actually blocking this enzyme could be lethal in patients due to loss of cortisol. One of the insights I was able to add to the development of this agent was that there is a rare autosomal recessive congenital syndrome of CYP17 deficiency in children. And this syndrome does not at any point result in hypoadrenalism or adrenal failure, because deoxycorticosterone and corticosterone do have significant, albeit less potent, glucocorticoid activity compared to cortisol. So when you block CYP17, you will still get significant glucocorticoid synthesis, although you lose testosterone and estradiol. Importantly, these children are often diagnosed in their teens with a lack of sexual development and hypokalemia and hypertension, in keeping with an ACTH-driven feedback loop driving increased levels of upstream hormones like deoxycorticosterone and corticosterone. In initial first-in-man studies conducted at the Institute of Cancer Research in Royal Marsden, we showed that this agent could truly inhibit this enzyme and reduce the synthesis of androgens, estrogens, as well as cortisol. The other really important insight that was developing around this time was that advanced prostate cancer cells can make their own hormones. And the critical thing that drove our development was that we felt that this agent would actually inhibit testosterone synthesis and estrogen synthesis, not only in the sex glands, the testes, and the adrenal glands, but also in prostate tumor cells. We went on to run phase 1 and phase 2 studies, both in the chemotherapy naive and post-chemotherapy disease subgroups, to show that this drug actually had anti-tumor activity, and these data are now published in the Journal of Clinical Oncology. And these are some of the PSA results. We had a PSA response rate in the order of 70% in the pre-chemotherapy setting, and the response rate of approximately 50% in the post-chemotherapy setting. We had robust anti-tumor activity demonstrated in bone scans and CT scans, including in liver metastasis, which was particularly impressive for us in young men with metastatic prostate cancer. We were the first group to actually ever study circulating tumor cells in advanced prostate cancer in a therapeutic trial. I was at the time running a study evaluating the prognostic power of CTC counts in advanced prostate cancer, and showed that CTC counts were highly prognostic in this disease, and that a fall in CTCs from high to low on treatment strongly correlated with an improvement in survival. We therefore in the study analyzed circulating tumor cell counts twice at baseline, then monthly, and we froze all the cells down for multicolor FISH analysis. We did this because, as I said, we had shown that CTC counts are prognostic. The more cells you have in blood, the worse your prognosis. And because we'd shown, as I said earlier, that a high to low count associated with better outcome as you go from high to low with treatment, and if you go from low to high with treatment, you have a worse survival. If you have a high count throughout, you have a very poor outcome as well. But if your count remains low throughout, you actually have the best outcome. And this led to the CTC count evaluation being cleared by the FDA for routine use in prostate cancer patient management. In our phase 2 studies and phase 1 study of Abiraterone, we did 2 baseline samples and showed that actually the correlation of those 2 baselines was really outstanding, with a Spearman R value of 0.88, in keeping with a highly analytically validated assay. We also showed that a fall in CTCs could be found quite commonly following treatment with Abiraterone in both the pre-chemotherapy and post-chemotherapy space in at least half of the treated patients. And this gave us real conviction that this drug truly had anti-tumor activity. May I remind you that many of these patients only have PSA as a measure of their disease. And this allowed us to have more evidence that this drug truly had more than just an ability to modulate androgen receptor signaling. In view of our concerns about the heterogeneity of this disease molecularly, we a priori hypothesized that perhaps TMPRSS2 ERG rearrangements by FISH would associate with a higher likelihood of benefit from Abiraterone. We also hypothesized that PTEN loss would associate with resistance to the drug, and the AR amplification could also associate with sensitivity to Abiraterone. We therefore set up a multicolor FISH assay in collaboration with what was then called Immunicon, particularly on Terstappen, and set up multicolor FISH assays on these CTCs, which we did for all the patients on these studies, approximately 100 or so patients, We also got all the archival tissue for these patients, and from a proportion of patients took fresh CRPC biopsies. What I can tell you is that what we showed was that there was significant intra-patient heterogeneity by FISH in the PTEN loss and in the AR amplification, but that the ERG rearrangements were the same throughout in one patient in all the CTCs. And in fact, the ERG rearrangement did not change in the whole history of that one patient, from their archival biopsy through their CRPC biopsies to their circulating tumor cells. So this was truly seeming to be an early event that did not change throughout the whole history of that patient's disease. We were able to get some preliminary pilot evidence that actually abiraterone had a higher likelihood of inducing a fall in PSA and a fall in circulating tumor cells in patients with an ERG rearrangement. But we did also see significant antitumor activity in the ERG unrearranged patients. Because of the substantial intra-patient heterogeneity in AR amplification and in PTEN deletion, we were unable, in our small patient number, to truly show any association between abiraterone sensitivity or abiraterone response and those molecular features. These data led to a large randomized post-chemotherapy randomized phase 3 trial of 1,300 patients. I think this is arguably the largest randomized phase 2 trial to date in advanced prostate cancer, and undoubtedly the fastest trial conducted in this disease. It finished accrual in just under a year. It compared abiraterone versus prednisolone, abiraterone and prednisolone versus placebo and prednisolone. Abiraterone was given at 1,000 milligrams per day, and that is the dose that truly blocked CYP17 in our phase 1 studies. The primary endpoint was overall survival, with typical secondary endpoints for this disease. The stratification criteria are on the slide. We published this paper in the New England Journal of Medicine a few months ago. This trial has shown in the primary analysis, there were 2 analyses. In the first analysis, a statistically significant survival benefit, as you can see on this slide, of approximately 4 months. The Independent Data Monitoring Committee recommended at the first analysis that we halt the study and give the placebo patients abiraterone in view of the data acquired. As you can see, the hazard ratio here is 0.64 with a p-value of less than 0.0001 and 95% confidence intervals for the hazard ratio of 0.54 to 0.77. We showed that there was significant survival benefit in both in patients that had only 1 prior line of chemotherapy and 2 prior lines of chemotherapy. I should say that the updated second and final analysis showed actually that the survival benefit actually increases to 5 months. Survival benefit was consistently observed across all the patient subgroups, as can be seen in this slide. All the secondary endpoints supported the superiority of the treatment arm: time to PSA progression, radiologic PFS, and PSA response rate, as you can see here. We now also have quality of life data showing that abiraterone-treated patients had much better pain control and quality of life than the control arm patients. So we have more options for patient care, but many challenges remain. These challenges include that it is now increasingly going to be more difficult to show a survival benefit for future drugs, because actually the more therapies we have, as in colorectal cancer trials, crossover will increasingly put trials at risk of confounding the survival benefit, and particularly in a disease where there are no progression-free survival approved endpoints. In fact, PFS is pretty much a meaningless endpoint in prostate cancer, advanced prostate cancer trials. So we urgently need surrogate biomarkers of survival for this disease that can be approved by the regulatory authorities for drug approval. You should be aware that most of these patients do not have radiologically measurable disease, and their disease is primarily measured by PSA evaluation. And these patients primarily have bone mets, bone metastases, that are difficult to measure and evaluate. So a priori in this randomized phase 2 trial of abiraterone, we did circulating tumor cell measurements twice pre-treatment and then monthly for all the patients on the trial. And I have a major interest in trying to develop surrogacy endpoints for advanced prostate cancer. And this is work I've been working on for about 7 years or so with CTCs. And more recently, I've actually teamed up with Howard Shear to pursue this work. I was awarded in 2005, 2006, and I think Paddy was actually on the committee, so thank you, Paddy, a Medical Research Council biomarker grant of over £1 million, to support also of AstraZeneca to do the CDC work. And our hypothesis was that actually a fall in CDC counts post-therapy could actually truly reflect all that survival benefit of treatment with Abiraterone, this biomarker panel. But to do this, we'd have to show that treatment effect truly associated with biomarker change, that the biomarker change truly predicted survival, that the treatment improved survival, and that we could actually really essentially measure all of that benefit or most of it through the change in the biomarker. Now, the statistical methodologies for determining surrogacy are multiple, and there is some controversy as to what the best methods are. But suffice it to say, with collaboration with Mark Buys and other statisticians, we have looked at multiple ways of looking at these data, and I'll come back to that in just 1 minute. I'm almost finished. These are the analysis that we did, CTC enumeration, 2 at baseline, approximately 1 to 4 weeks apart, and monthly after that, and also at the end of treatment. We also looked at other standard prognostic biomarkers of outcome. I should say that the 2 baseline CTCs were highly concordant in the phase 3. The R value was 0.82. We have data on approximately 1,000 patients for the baseline and about 800 patients really at least baseline and 1 post-treatment time point. We have shown that Abiraterone does improve survival. I've shown you that already. The Abiraterone does impact circulating tumor cell counts. So as you think about drug, survival benefit, biomarker, we have shown an association between drug and survival, between drug and CDC counts, between CDC counts and survival. And actually, when we analyze how much of that benefit between treatment effect and survival the biomarker panel captures, we can show through sophisticated statistical analysis that actually if you add the CDC count into the model, the CDC conversion count completely removes the impact of treatment on survival. And the statisticians assure me that this essentially proves that actually a CDC count fall from more than 5 to less than 5 is a true statistical surrogate for Abiraterone of overall survival. So we have the first randomized phase 3 trial to show that a CDC count fall is a surrogate of survival. So in conclusion, we have made significant progress. We have multiple new agents to treat our patients suffering from this disease. We potentially have a new surrogate of survival and a means to actually do biomarker studies using circulating tumor cell analysis. And we importantly have an improved understanding of drug resistance in this disease. But much work still needs to be done. This is work from one of my PhD fellows showing the variable survival from different subtypes of prostate cancer. And I think molecular subdivision or molecular stratification of this disease is key to running trials that will be positive in the future, as we've heard throughout the day today. And I want to finish with a slide from Arul Chinian and Chris Maher, friends of mine at Michigan at Ann Arbor. We now have at least 22 different subtypes of prostate cancer, maybe even 24. Some with RAF rearrangements, some with ERG, ETV1, ETV4 rearrangements, even RAS rearrangements. It is imperative that we start designing trials that are molecularly stratifying this disease. So thank you very much.